My name is Stuart Lavery. I'm a consultant gynecologist with a special interest in reproductive medicine and surgery, and in particular fertility. I've been in this field for many years. I qualified as a consultant in 2002, and I've been a medical director here in London for over 20 years. I also work on the NHS, where I'm Divisional Director of Women's Health at UCLH and an Associate Professor at UCL. I started doing IVF in the 1990s, and at that stage, there wasn't a huge choice of drugs, and Cyclogest was our go-to progesterone. And over the years, that hasn't really changed. So we were getting great effects with Cyclogest way back then, and we still do today. Cyclogest has a long history that really underlines its efficacy as well as its safety. It's well tolerated by patients, and it also represents good value for patients as well. So we've been quite supportive of the product for many years. I think there's a strong preference for patients to take progesterone via a vaginal route as opposed to an injectable route. I just think these patients go through an awful lot in terms of injectable and needle administration. And I think to add another one, particularly one that might be quite painful, is something that patients would rather avoid. I think perhaps two reasons for the patients preferring the vaginal route as opposed to the injectable route. The first one is pain and discomfort. That is going to be significantly more with the injectable, in particular if it's an intramuscular injection. These are large volume of oily products which hurt, not only when they go in, but for many, many hours afterwards. And we've had some dramatic side effects, including abscesses, difficulty walking, and sometimes even nerve damage. So one has to be very careful with a large volume intramuscular injection. Some patients may also feel that the impact of local absorption might be beneficial. I also think if patients do want to do a bit more due diligence and evaluation of the drugs that they're using, the fact that this is a natural progesterone is also something that would be attractive to. There are many, many years of patient use of Cyclogest. There are also some concerns when synthetic progestogens have been compared with natural progesterone in breast cancer patients. And so I think there is a reluctance amongst patients, and they need extra convincing to take a synthetic product over the natural product, which seems to be much more acceptable. We did evaluate the gel when it first became available. And at the time, there were two things that made us pause. One was the cost of the gel, and the other was the patient experience. So many patients found it slightly more tricky to administer, slightly more messy. And to change practice, one often needs a very compelling reason. We didn't find that compelling reason at the time, and hence we've continued with Cyclogest. We do see many patients that are both fertility patients as well as miscarriage patients. And with the advent of the new NICE guidelines based on the Lancet papers, we have now changed our practice, and we now discharge the patients on Cyclogest support. We leave the decision on when to stop the Cyclogest up to the obstetricians or preterm clinics that the patients are actually seeing.